Okay, welcome everybody. Thank you for joining us this evening for our meningioma support group meeting. The topic today that I'm going to discuss is kind of the general thought process on how to approach minimizing risk and maximizing surgical outcome if you're undergoing surgery for your meningioma. And I want to preface this by saying that not all meningiomas need surgery. Small ones can be watched. Other meningiomas can be treated with forms of radiation or radiosurgery. So specifically tonight, we're going to be talking about meningiomas that are, patients who have meningiomas that are candidates for surgery. And a lot of what I'm going to be talking about today is the behind the scenes thought process in terms of how we as neurosurgeons go about thinking about approaching a meningioma. So when you see a neurosurgeon in clinic and they're discussing your case about how to treat your meningioma, they may say, well, I'm recommending surgery, and then tell you why. And a lot of what I'm covering tonight is going to be the thought process behind that. So I always like to start with telling patients that there are four primary goals of surgery. The first goal is to make a diagnosis or a pathology diagnosis or tissue diagnosis, however we want to call it. And that's because the majority of people that are undergoing surgery for their meningiomas have not had prior surgery before. And so we're presuming that the tumor that they have is a meningioma, but we don't know for sure. And there are some tumors that are less common than meningiomas that can certainly mimic a meningioma. So I think it's important to make a tissue diagnosis. This involves taking some of the specimen at the time of surgery and handing it over to the pathology team. They will run a series of tests using special dyes and stains to determine whether this is a meningioma, and if so, what grade of meningioma the tumor is. In this process of making a diagnosis does take several days. It's usually about 3 to 5 work days for them to generate the final pathology report. But oftentimes at the time of surgery, the pathology team is able to tell you that they at least have a meningioma, something that is consistent with what the thought process of undergoing the surgery is all about. The second goal is to remove as much of the tumor as possible. And in neurosurgical circles, we use the term maximal safe resection. And what that means is if you're going to do a surgery where you're going to go in and you're going to open up the skull, it doesn't make sense just to take a small portion of the tumor for biopsy or diagnosis and then close everything back up. I mean, if you're there and you're looking at the tumor and you can remove portions of the tumor safely, that's a second goal of the surgery. A third goal of the surgery is what I call symptom alleviation, and this is the reason why most patients kind of have a meningioma discovered and then undergo surgery. They have some symptoms, whether it's a headache or seizures or some other neurologic deficit. The goal of the surgery is to alleviate or reduce or resolve these symptoms. Oftentimes removing the majority of the tumor takes the pressure off the brain, and that alleviates the symptoms. Sometimes just removing the tumor reduces the irritation of the brain. In the case of seizures, that could alleviate symptoms. And the last goal of surgery is to do everything above, as safe as possible. So let's talk about the process of how a patient with meningioma will kind of work their way through the system. And so I'm going to start in the clinic setting. And this is when a patient diagnosed with a meningioma is being evaluated in clinic for the first time prior to surgery. And a lot of times patients are anxious if they've been just diagnosed with a meningioma. They're starting to think backwards and determine which of their symptoms over the last several months are potentially related to the tumor. And in many patients, it's very easy to start attributing symptoms to the meningioma that may not really be related to the meningioma. So I always like to figure out which symptoms are potentially related to tumor, and then you can have a frank discussion with the patient in terms of what the expectations are. We can say, out of these 5 symptoms that you're telling us about today, we think 3 are related to the meningioma, and we think those 3 will have a good chance to resolve with surgery. The other 2 symptoms we don't think are related to the meningioma tumor, and therefore may not get better with surgery. So something along that lines of process there. So what are the common symptoms for meningiomas? Seizures and headaches are the top 2 symptoms that we typically see. About 1/3 of patients present with seizures that have meningiomas. And in this case, patient did not know they had a tumor, had 1 or more seizures. That prompts a workup, and a meningioma gets discovered. Other patients, of another 1/3 of patients with meningiomas, present with headaches. And these are typically, in hindsight, headaches that a patient often says, well, I wasn't sure if they were tension headaches or stress headaches, but these headaches persist long enough. And if you see a physician with a series of chronic headaches, one of the tests that is typically ordered is a brain MRI scan, and that can lead to some of these meningiomas being discovered. So 1/3 with seizures, 1/3 with headaches. The last 1/3 of patients present with a variety of other symptoms, and it depends upon meningioma location. I've listed some here. There are some patients with meningiomas who have their tumor discovered as an incidental finding. And what that means is the patient's undergoing a workup for something else, and a meningioma gets discovered. For example, patient is in a car accident and strikes their head on the windshield, and in the emergency room, because they hit their head, the patient undergoes a brain scan, and a meningioma is discovered. So that would be an example of a meningioma that was discovered as an incidental finding. So we talked about seizures. They present in about 1/3 of patients with meningiomas. That's generally caused by brain irritation. And if you can see this little cartoon in the bottom corner here, the meningiomas, they grow off the inner lining of the skull, and they push on the brain, they indent the brain, and that can create some irritation in the brain, and that irritation can cause a seizure. So what happens if you have a meningioma and you have a seizure? The first thing that typically happens is a physician, and it's usually the emergency room physician who is seeing the patient for a first-time seizure. The emergency room physician puts a driving restriction on you, and that's because physicians are required by California law to notify the Department of Motor Vehicles if somebody has a impairment that would affect their driving. And a seizure where you lose consciousness and pass out is certainly one of those impairments. So typically what happens is, before a patient even gets to my office, they've had some restrictions placed by the ER physicians. And one of the goals of treating the tumor is to try to see what we can do to get these restrictions lifted. So in addition to driving restrictions, there can be some work restrictions. If you're at risk for seizures and your job is to clean off roofs or climb ladders or do anything that's off of the ground, that may result in a restriction on that type of work. Also, if someone has a seizure disorder, it's also not recommended that they be left or do things alone by themselves for long periods of time. So don't go hike the Rocky Mountains by yourself for a week if you have a seizure disorder, because if you did have a seizure, nobody would be there to help you as well. The restrictions for seizures sometimes can affect kind of learning ability. If a patient has a series of seizures that are not well managed, it can impact a patient's ability to learn new information. So one quick slide on seizure medicines, and we'll move on to the other symptoms. Typically, seizure medicines are given to reduce the chance of seizures. They work pretty well. There are a variety of standard medications that have been used for decades. The main thing to keep in mind is sometimes patients have side effects for these seizure medications. with the main side effects kind of feeling a little tired, drowsy, and having some balance problems. So what happens with seizures if you do surgery for meningiomas? The surgery removes the tumor, so this removes the pressure on the brain, and removing the pressure on the brain is thought to reduce the brain irritation. And because of this, surgery has a fairly high chance of eliminating pre-treatment seizures, well over 50%, sometimes in the high 80% chance of eliminating seizures. There's always a small risk of seizures in the immediate postoperative period because the removal of the tumor with surgery can create some transient brain irritation that can result in a seizure. So headaches, a big cause of symptoms for meningioma patients. And the challenge with headaches is they're usually nonspecific. For example, if you have a seizure and you've never had a seizure disorder before, it's pretty clear something happened. But with headaches, we all get headaches. We get tension headaches, and a lot of us have migraine headaches. And most people that have these headaches don't have a brain tumor. So when do you get concerned that you might have a brain tumor if you're having a series of headaches? So typically, headaches from brain tumors are usually constant. It's an unrelenting headache that's been going on for weeks and weeks at a time. And certainly I tell patients, look, if you have a headache that goes more than a week, then that's when we maybe need to start thinking that these are more than just routine headaches. There's some data that shows that patients that have headaches from brain tumors, the headaches tend to be worse in the morning and then get a little bit better during the day. But that's not necessarily the case in all tumor patients. The headaches are thought to be irritation of the tumor on the inner lining of the skull. So the tumor grows off the skull, irritates it. Maybe that's causing some headaches or pressure. The treatment for headaches typically is, the standard headache medications, occasionally steroids. And then with surgery, headaches are often easily improved because, as you can imagine, as you can see in this picture here, this patient has a large meningioma pushing on the brain, and it's not uncommon to expect that the headaches would get better if you took that pressure off. So here's a larger picture of what we see in terms of brain compression there. So if we look kind of more at the microscopic level, these are the different layers of tissue. You can see at the top is the bone of the skull, and the bottom is the brain. And you have this blue and orange layer of what we call meninges, the dura and arachnoid layers that are around the brain. The meningiomas occur in this layer, in these layers, the arachnoid layer, and the irritation that these meningiomas have on the adjacent bone and brain is presumed to be what is the cause of headaches. So what happens if you have a patient with a meningioma that presents primarily with headaches? What are the outcomes with surgery? The first is that by removing the tumor, you are removing the pressure on the brain. And removing the tumor also eliminates any tumor pieces that could be irritating the inner lining of the skull. So with headaches, there's a fairly high chance of symptom relief with surgery. But again, headaches are non-specific, so I think there needs to be a pretty detailed discussion with your neurosurgeon about, the expectation. Are these headaches really being caused by meningiomas, the headaches that any particular patient has? Okay, so after you're evaluated based on symptoms in clinic, and the neurosurgeon recommends surgery, there's a series of questions that usually come up. And I think it's important to have this discussion with your neurosurgeon prior to the surgery, just because obviously after the surgery, you're going to feel tired, fatigued, you won't be able to necessarily want to have long conversations. So I think it's important to set the expectations of what the outcomes of surgery are going to be. So these are the type of questions that I try to typically cover for a patient that's being seen in my clinic. The first question is, how long will my surgery be? And that is a question that is highly variable depending on size and location of the tumor. So patients under general anesthesia, they have no perception of time. So it's not like they will understand whether surgery is taking shorter or longer. But I think patients always like to know, how long will I be under anesthesia? If I go into surgery at 8 a.m. in the morning, when it's expected that I will be out of surgery in the recovery room. So another question that sets expectation is who is involved with the surgery and what are the roles of each person. So to do a surgery on a meningioma usually requires about 10 different people. So it's a pretty big team. It's not as simplified as some of the TV shows make it out, that there's just a patient and one person in the operating room operating on them. There's a big team of people such as nurses, neurologists, anesthesiologists, and other support personnel that are involved in the surgery. And each of these people have a very specific role. Like I'm not intubating the patient. That's the anesthesia doctor's job, just like you wouldn't want the anesthesia doctor doing the brain surgery, for example. So everybody has a very specific role. And I think it's important to know what each person's role is in the process. A third question that's, I think, useful to set the expectations is, where am I going to go right after surgery? Do I need to go to the ICU? We've gotten pretty good at being able to predict which patients can safely go to the ICU and which patients need to go to the regular floor after surgery. But I think it's important to, make sure that the patient understands that. If its the expectation is to go to the ICU based on the size of the tumor, then there shouldn't be any shock when the neurosurgeon tells the family after surgery the patient is leaving the OR going to the ICU. But as you can imagine, if you don't have this discussion with the patient and the family prior to surgery, going to the ICU may sound like, well, the patient's not doing well or was sick from the surgery. And that's not necessarily the case. A key question is, when can my family see me? How soon after the surgery can they come in and see me? And typically, it's within about an hour and a half to 2 hours after surgery that families are let in. Part of the reason is, after the surgery, it takes the nursing staff a while to do their checklist, get the patient settled in, and it's not a good idea to have family members, asking the nurses questions and things like that when they're trying to do, their review of the patient. So we usually say, let the nurses tuck the patient in, get them settled, and then we can let the family in. Couple more questions. How long will I be in the hospital? This is partly related to the size of the tumor and the length of the surgery, but typically it's 2 days. If a patient of mine has surgery on Monday, they typically go home Wednesday. And I like to set the expectation of this in clinic as well before the surgery, just so there's no confusion, once the patient's out of surgery in terms of the expectations of how long they will be in the hospital. Sometimes the hospitals are, very nice and the food's good and patients want to stay a long time. But that just can expose them to, hospital-acquired infections and other things that could happen if you're in the hospital for a long period of time. Another question is, what milestones do I need to achieve to get out of the hospital? This is what is typically called activities of daily living, or ADLs. And these are things like feeding myself, dressing myself, washing myself. So what do we need to do to if a patient has had surgery for meningiomas, to get them out of the hospital? There's 3 key milestones. You have to be walking around, not just lying in bed or sitting to a chair. You have to be walking around the hallways, making laps around the nursing station. You have to be tolerating regular food. So that means more than just tea or clear liquids. You have to be eating basically regular food. And you have to be able to get to the bathroom on your own, and not just get to the bathroom, but actually either be able to have bowel movements or urinate. So we know that part is recovered from the anesthesia. So typically the checklist is walking the hallway, eating regular food, and getting to the bathroom. And if you do all those, you have the opportunity to get out of the hospital. Once you get home, there's not too many restrictions. There's some restrictions on how much you should be lifting and trying to keep the incision dry and things like that. But typically, there's not a lot of restrictions on patients once they get home from the hospital. The last couple of questions: what medication will I need to be on once I'm discharged? Typically, there's about 4 different medicines that a patient is given. The first is pain medicine. You take it if the regular Tylenol is not working. The second would be sometimes it's a steroid medication, which is a medication to reduce inflammation. These are not bodybuilding steroids, or anti-inflammatory steroids. Patients are typically on those. Patients typically also go out on a stool softener. And a stool softener is a medication that prevents the patient from getting constipated. So those are the type of medicines that one typically goes home from the hospital. And then the last question that I commonly get asked is, do I need to have somebody around me when I'm home from the surgery? And the answer is, if you're meeting all these activities of daily living, the walking yourself, feeding yourself, dressing yourself, you don't really need to have specific family members around you once you are at home. There's some few exceptions if you have a seizure disorder and things like that, but generally you don't need family members to be around you if you've planned the process out correctly. So let's talk about the preoperative tests. What kind of tests would a person have as part of a meningioma workup? Sometimes physicians go straight to an MRI scan. That's generally the first scan that a patient has for a meningioma. Other times a CT scan is obtained. It's easier to get. It's less expensive. The scan can be done in about a minute on some of the newer scanners. So one of those 2 scans is typically done. Next, we're going to talk about some other adjuncts that are potentially helpful for meningioma evaluation scanning. The first is what's called an MRV scan, or MR venogram scan. This is a scan that looks at some of the blood vessels around the tumor, particularly the veins of the tumor. Veins are large blood vessels that drain blood from the brain back down to the heart. So if you have something going on with those veins, like a blockage in the vein, or the tumors invading the venous sinus, it's important to know, when an MRV scan is helpful in that sense. The next scan is a functional MRI scan. This is a scan to determine if there are any important neurological tracts that run along the tumor. So what that means is the tumor located next to the motor cortex of the brain? Is the tumor located next to the visual cortex of the brain? And all those are identified on a functional MRI scan. The last process is a procedure called embolization, and this is a very useful process to reduce blood supply to the tumor. Typically, before the surgery, embolization is performed if the tumor is large, and that's because we're trying to shrink the blood vessel supply to the tumor. The less blood vessels going to the tumor, the less of the load. Now, having said that, doing the embolization prior to surgery has to factor in any potential swelling that could happen after the embolization. If you're going to glue the blood supply to the meningioma, which is what embolization does, make surgery easier, tumors can sometimes swell, and that is something that needs to be factored in. But embolization is a very good adjunct that can be done on the day of surgery, prior to the surgery, to reduce the blood supply to the tumor. What happens in the operating room once a patient gets to the operating room? I think it's important to, first of all, to have a good communication with the anesthesia team. So you want to tell them, what the expectations are from the surgery. We think this will be a 4-hour surgery. The tumor is in a very superficial location, should be fairly easy to remove. We don't see a lot of blood supply to the tumor, so we don't anticipate a lot of blood loss. So that's important information to communicate to the anesthesia team. The choice of their anesthetic medications and how much they give is somewhat of a function of when they think you're going to finish. The last thing they want to have is to have the surgery finish, but they had expected you to go on for another couple hours, and now they've given you some long-term anesthetic medication, and then you're just waiting for the patient to wake up at the time of surgery. Similarly, when you do meningioma surgery, there's often, and for me, this is fairly routine, to have a neurology team in the operating room that's going to monitor the brain activities of the brain. This is where to, and typically they want to know where to put these tiny electrodes in the scalp so they can record brain activity. They don't want to put it in a location where you're going to make an incision and do surgery, but they definitely need to put it close enough to where they are going to monitor. Another situation in the OR is like, how are you going to position the patient? We kind of take this very lightly, but when you do brain surgery, you're actually immobilizing the head in a fixation device, and that's so it doesn't slip during the surgery or there's any motion if there's an earthquake or something like that in the operating room. So it's very important to consider how you want the patient's head positioned. If you're going in on the left side, you might want the head turned to the right so that the left side of the head is facing upward. If you're going to approach a tumor kind of in the midline, maybe you want to position the patient in a supine neutral position. Typically, we like to say position the head above the heart, and that's just we're talking about from the floor of the ground. We want the head to be higher than the heart, because if you have the opposite, if you have the head below the heart, then blood rushes to the head and you're more likely to get some venous bleeding. You want to pad the extremities, arms and legs, to make sure there's no pressure sores that can develop as a result of a surgery and not having the patient move. So this is an example of what I would say you'd want to communicate to the anesthesia team and the neurology team before the start of surgery. So this is a meningioma here. We see it right here, about the size of a golf ball. But surrounding the tumor, there's a wide range of edema that we can see. This edema is this darker gray area. This is the area of the brain that's swollen. You can see it's putting pressure on the brain. Part of the right side of the brain is pushed over to the left. So this is something that you want to communicate with to anesthesia prior to the start of the case. You might want to say, hey, they have a lot of swelling. Can we give some medicine for swelling? You may want to not give them a lot of IV fluids during the surgery. If they already have a swollen brain, more IV fluids would go into this area of the brain and potentially make things worse for the patient. Okay, so now we're at the point where patients in the operating room, they're asleep under anesthesia. Where you've made the skin incision, how are you going to open the bone in such a way to maintain safety? So one of the key neurosurgical principles is the bone opening should be adequate enough for the neurosurgeon to maintain control of the surgery during at all times. So if you make a really tiny opening, it may be hard to get equipment and instruments in. It's more of a ship in a bottle phenomenon. The patient might heal better, but the surgery could take twice as long or 3 times as long, because you can't reach the tumor if the bone opening is too small. A larger bone opening allows some light to get in, allows you to see adjacent structures. We talked about the functional MRI scan showing us where the trajectories of tracks are. Tracks being the fiber, like the pathways of the neurons. Typically, from a surgical approach, you want to avoid trajectories through the brain that will be associated with increasing risk. So if there's 2 different routes, a brain tumor, and one route goes through the motor cortex and the other route doesn't, then you might want to choose the route that allows you to avoid critical structures. We talked also about medications that we facilitate relaxation. This is the same slide again. While you're opening the bone and retaining with the tumor is going to cause a lot of pressure, the brain may try to emerge out of your bone opening, and so it's important to factor that equation and give medications to help facilitate the brain relaxation. Okay, so now you've opened the bone and you're down at the tumor. What are the strategies to find out what is going on? The first is it's pretty much standard practice to send tumor tissue to the pathologist to have them look at it right away. So one of the first things I like to do when we first land in the outside of the tumor is get some for pathology and see if are they around? Are they still on lunch break and or whatnot? Do we need to get them back in here and have them take a look at the pathology? But you want to get them to look at this right away. The pathology review can take 20 to 30 minutes. So while they're assessing the first tissue that you gave them, you can continue to resect additional tumor. Sometimes meningiomas can be fairly bloody. Other times they're very variable. They're invariably minimal blood loss. So the key for meningiomas is to don't let bleeding get out of hand. Don't have the tumor bleeding from 5 or 6 different locations. Work on one location. If there's bleeding in that location, work to stop the bleeding before you move on to the next portion of the tumor. And I think it's very important to have clear communication teams with neurology and anesthesia, especially toward the end of the case, when things have been going on for a long period of time. And everybody might have the original kind of game plan and discussion on the patient might have been not on the top of everybody's mind. So let's talk about closure. You got the tumor out. I think it's important to always look in the resection cavity of the tumor to make sure that there is, not some tumor that you may have left behind during the resection. Oftentimes when we do these resections, as we remove tumor, the brain moves back into the field, and that can obscure small remnants of tumor. So you want to look around before you close it to make sure that there's no other tumor that's been left behind, that you've achieved the maximal safe resection. Hemostasis is kind of the medical term for making sure there's no bleeding, no active bleeding going on. So we have a series of equipment, these bipolars that cauterize any bleeding vessels. It's very important to achieve hemostasis before you close the brain, because you certainly don't want bleeding into brain tissue. The other part of surgical closure that is, maybe now more prevalent than before is how to close up the dura. That's that leathery lining on the outside of the skull. In the inner layer, the outermost inner layer of the skull is called the dura. This is a leathery layer that you would sew back together to prevent leakage of any fluid. So we have a variety of kind of patches, synthetic patches that we can use to repair the dura if the native dura is not available. And some situations it's not available because there's tumor in the dura, and when we resect the tumor, that portion of this dural lining will go. There's a variety of sealant products. They're kind of like crazy glue, where you would layer it over the dural closure to make sure that's kind of watertight. It's fast drying and gives a good coverage level. So if you now close everything up, anesthesia is working on taking the breathing tube out of the patient. What's the postoperative recovery course? The first decision tree is, does the patient need to go to the ICU, or is the recovery room sufficient? Meaning the patient would go to the recovery room and then to a regular hospital floor bed, not an ICU. This is a debate that, typically you have a good sense of where the patient needs to go after the surgery, as the surgery is winding down. If everything went well, everything went smoothly, maybe the patient can go to the recovery room and then to a regular floor bed and bypass the ICU. The postoperative course is also governed by a series of what's called neurological checks. And that's basically assessing neurologic functions, squeezing fingers, wiggling toes, closing your eyes, things like that. Are you able to hear those? Are you able to have an exam where those can be done to make sure that everything's okay? The other expectation of this postoperative course, and again, is getting back to what we talked about in the beginning, is what are the expectations? Somebody could certainly have a seizure in the recovery room or in the ICU after the surgery, and that could be just a normal event just from having to undergo the surgery. We don't expect it in all patients, but a good 5 to 10% of patients will have a surgery in the immediate post-op period. So we got to know not to be surprised should that happen. After the surgery, once we close the skin up, there could always be a little bit of swelling along the skin. It's like if you sprain your ankle, there can be some swelling that occurs, and that can, it can look concerning if it's swelling along the side of the face where the surgeons approach the procedure. The also the expectation in the post-op, of course, is when will my energy level return? If it's suppressed from the anesthesia, I feel tired. When is it reasonable to think that I'll be able to, get enough energy? And then a parallel question is, when is it safe to go back to work? The answer to both those questions, depending upon size of the tumor, how big the surgery was, and how the patient's doing in the immediate post-operative period. But generally, energy level gets back up close to normal within about 3 weeks of surgery, and most patients are able to return to work within about 4 weeks of surgery. So I think I'm gonna. That's how the final step of the course where the patient's in the recovery room. I'm going to stop there and see if there are any specific questions that I can answer regarding this thought process on how to think through working up a patient and treating a patient with meningioma. It may be the best way is to submit any questions that you have to there's a question and answer icon on the Zoom bar that should allow you to submit questions there, and I'll just go through the list of questions that come in and try to answer them. So let me go through the list right now. Okay, so the first question actually that came in was a patient already had a meningioma removed, so there's this webinar is a webinar applied to that, and the certainly hopefully the process that you went through to have your meningioma removed was similar to what I've just kind of covered here, the thought process. It sounds like you're doing well from the surgery, so a lot of what I shared today is probably what happened behind the scenes during your resection of the tumor. Okay, other questions that people have? Here's a question. A 61-year-old female with a right-sided mouth droop. MRI showed a extraaxial mass. Extraaxial just means outside the brain, but inside the skull. Likely to be a meningioma. So on the frontal lobe, it's about 1 centimeter, so about maybe half an inch by about a quarter of an inch. Stable compared to 2014. Wow, okay, so that's good. That's 9 years, it hasn't changed. I'm not having any headaches or seizures. My right-sided mouth droop is diagnosed as Bell's palsy. Do I need surgery? I'm waiting for a neurosurgery appointment. Okay, so the good news is that your MRI scans showed that there's been no change in the tumor from 2014 to now. So that's 9 years. That means a tumor, if it ever is going to change, will be likely very slow. I do agree that the location of the meningioma should not explain your right side of your mouth droop. So that's probably is the Bell's palsy. That's typically a viral infection treated with steroids and antiviral medications, and typically gets better over time. In terms of the meningioma, if there's really no growth and you're not having any symptoms, you can certainly continue to monitor and watch the tumor. There's no reason to do a surgery on a tumor that you've known about for a long time and that is not changed, as long as you're comfortable with this monitoring process. So I'd say overall for this case, no rush for surgery at this point. Okay. The next question is, in the intraoperative pathology, is that the evaluation to determine whether a tumor is cancerous or not, or classify what we call the grade of the meningioma is so grade 1, 2, or 3. The so when the intraoperative pathology is commonly called what's called a frozen section, and they freeze some tissue into a paraffin block of wax, and then they cut through the block with these thin slices, and they look at those under the microscope. So that's called a frozen section because of the frozen block of the paraffin, and they can oftentimes tell whether something is a meningioma or not. They can classify a meningioma separate from a different type of tumor, but they won't necessarily give you the type or grade of the meningioma at the time of the intraoperative frozen section. So the final pathology report, which comes back a few days later, will typically grade the meningioma at that time. So the short answer is typically they can tell you whether on frozen section the tumor is cancerous or not, but they will not be able to tell you on the frozen section the type or grade of the meningioma. The next question is from Jeff. Do surgeons usually have a sense of what percentage of a tumor could be removed versus left behind after that surgery, or is this assessed via a postoperative MRI scan? So Jeff, the answer to this question is there's a couple different ways to answer this question. Smaller tumors obviously are much easier to remove than larger tumors. So for smaller tumors, it's very clear whether you've got a complete resection or not. For larger tumors, it can be more challenging, like how much tumor is left in the skull, how much tumor is left in the soft tissue. I think most surgeons are pretty good about estimating how much of the tumor they got behind on a percentage basis, how much they were able to take out versus leave behind. Obviously, the postoperative MRI scan is kind of the gold standard, but there have been patients where I thought I had a perfect resection. The MRI scan showed there was some tumor that was hidden, a small amount of tumor that's left. There's been other situations where I thought I left some tumor behind, but the MRI scan looked great and there was no tumor visible. So I think surgeons are pretty good about getting into the ballpark of how much tumor was left behind. And I think it's a fair assessment, but I don't know really any real place that would say we're not going to do a postoperative MRI, because that's going to be effectively your new baseline. The next question, I heard approximately 10% of the population has meningiomas and many don't even know, and most of these are women. Is this true? And if so, why? Yeah, the meningiomas are the most common benign brain tumor of the brain. And they can be so slow growing that it's possible for patients to have a meningioma and not know about it at all, and then maybe pass away from some other medical problem, for example. So there are definitely patients that are having meningiomas, but we just don't know about them and they never get diagnosed. In terms of the distribution, generally there's a 3-to-1 to 4-to-1 ratio of women to men that have meningioma. So let's say 4 times as many women as men that have these meningiomas. And the one question is why? It turns out that many meningiomas, about 1/3 of meningiomas, have estrogen receptors on them, and over 75% have progesterone receptors on them. So it's possible that particularly in the perimenopausal, postmenopausal period, where you're having some changes in these hormone levels, particularly among the females, that may be somehow inducing the meningioma to potentially grow, because if these meningiomas have these estrogen receptors and during menopause there's a change in your hormone levels, maybe there might be some stimulation of those receptors that prompts the meningioma to grow. But that's thought to be the reason why it's more common in women than men. I've had meningioma surgery on my thoracic spine for an incidentally found tumor. How likely is it to have any kind of neurologic problems? So I think the way this question is worded is it sounds like that there's been no surgery yet, is my take on this. And the question is, what kind of neurologic problems could I have if I have surgery for a spine meningioma? So the best predictor of how patients do after surgery for, let's say, a spine meningioma is what kind of shape they were coming in. If you're talking about a resection of a meningioma and you're not having any real symptoms at all, other than what led to the meningioma being diagnosed, the chance of having a neurologic problem is low. Now, if the tumor is already causing a lot of problems via pressure, or if it's a much larger than typical meningioma, then any of the symptoms you listed, walking, leg stiffness, loss of sensation, unusual weakness, that would all theoretically be somewhat fair game for symptoms that a spine meningioma could have. Next question, does surgery to remove a meningioma reduce the chance of developing breast cancer? Not per se. The meningioma is not thought to release the female hormones or anything like that, so I'm not aware of any clear-cut cause effect here. Next question is, are there better or worse diets in form of diets in terms of slowing or promoting tumor growth, and any foods to avoid? Yeah, this is a pretty controversial question, but pretty common. Patients all want to say, I want to live as long as possible after my meningioma. So what can I do to kind of facilitate that? I think the first comment is, I think this question is right, definitely on track. I mean, we do expect patients that really want to focus on nutrition and health after their surgery, but there's not really a lot of diet changes that are necessary prior to surgery or even post surgery. Post surgery, you want to have a lot of protein, and that's important for recovery here. But generally, I don't typically say there's foods that you should avoid when waiting for surgery for your meningioma. Another question, my husband's meningioma was successfully removed. You were okay. I guess this is a patient that has come before. They must have listened to some of the prior videos. It says, I received a lot of help on the platform. I wanted to thank you for continuing to do this. So it looks like it sounds like that these type of webinars have been helpful, at least to some of the patients here. The actual question that this patient has to do with whether hereditary issues. Our daughter it says our daughter was tested in the early age 19 for possible NSF. I think that means fibromatosis, but she had only 4 markers of the 7 needed for diagnosis, so not truly fibromatosis, but you recommend genetic testing. This is a little bit of a tough question because there's pros and cons of doing genetic testing early on asymptomatic patients. On one hand, I think it's important to let people decide if they do want to see a raise in, if they do want to see a let's see, if they do want to see if you do want to get tested for markers, there are genetic testing for the neurofibromatosis, and that might give you some methodology to determine how frequent to get MRI scans. And that would also give you predictive value in terms of whether this daughter could potentially pass on the genes to her offspring. The only issue is that like anything in the medical chart, if you start documenting disorders, they become part of your medical chart. And if there's any situation where you're trying to establish like life insurance or anything like that, and you document a number of medical problems in your chart, that may either preclude you from getting that coverage that you want. So I think the answer is, which I recommend genetic testing, is a little bit more complicated than can be kind of described in a webinar. I think it's important to this would have to be a detailed discussion, like what are the pros and cons of the current situation, and what are the expected, what are the expectations here. Let's see, there's somebody wrote in a pretty long one here. Let me do the short one first. You mentioned the perimenopausal hormone changes. Okay. I had my meningioma surgically removed and subsequently had CyberKnife treatment. My scans have been stable now for 5 years. Is it advisable to avoid taking hormone treatment for menopause because of the meningioma history? So the reason to take hormone replacement therapy is to actually preserve the bone function in women. The lack of the hormones that occur in the perimenopausal, postmenopausal period cause osteoporosis. One of the factors that cause osteoporosis, and hormone replacement therapy, among others, helps you maintain the bone density. There also, obviously, hormone replacement therapy takes care of things, the symptoms like the hot flashes that can be, for some people, quite bothersome. So typically, I think if it's been 5 years or more and there's been no recurrence of a meningioma, I think it's certainly reasonable to consider taking hormone replacement therapy for the benefits that it could provide. Okay. Next question is a little bit long question, so let me kind of take a look at it. So patient had a craniotomy to remove a meningioma. It's a retrosigmoid craniotomy, so it's kind of behind the ear. They got a near gross total resection. What that means is nearly all the tumor could be removed. Near gross total generally means like 90-95% of the tumor was removed. Sounded like the big concern was, based upon where this tumor is located, there was a concern for some swallowing dysfunction after the surgery. And so there's some concern for that. The patient had the surgery, again, near total excision was accomplished. And then sounds like the patient did well after the surgery, no swallowing issues, some mild headaches, and some mild balance issues. They had a postoperative MRI scan, which showed some small areas of enhancement. Those could be the areas of the residual micro portions of the tumor that would account for, not a complete resection, but the near gross total resection. So the question is, do these small areas need to be treated with radiation? This is a little bit of a tough question because you need to know specific factors that weren't put in here, and obviously I don't have the films. But age of the patient is important because a younger patient is much more likely to have a recurrence over their lifetime than an older patient. The appearance of what these areas of enhancement look like, and whether or not, if the treating surgeon says that this is where the residual tumor was, and that matches these areas of enhancement, that's pretty convincing evidence that there might be some residual there. There's some advantage of treating small residual meningiomas early with stereotactic radiosurgery, and that's the primary advantage, is to prevent the need to have another prior surgery. So again, to answer your question, size-wise, these sound like they're a candidate for radiosurgery. Not clear if these are completely changing in size or not. It doesn't sound like there's much change going on, but it also sounds like you've had a pretty formal discussion at a center of at a center radiosurgery conference program at a medical center to give you input here. So the question here is, do I need upfront radiosurgery? Meaning, should I treat these two little spots now, or should I just follow them? And then again, this is a very personal decision. There's pros and cons to each one. I do think that kind of just watching the tumor, if you choose to watch the tumor, you shouldn't really be surprised if there is some change over time. So if you watch the tumor, don't be surprised that there's growth in the future. Watching the tumor is not a total risk-free thing. Having said that, the first few scans that you get after the surgery are important to determine the kind of frequency of following. A gross total resection where all the tumors is removed probably doesn't need to be followed as closely as a partial resection of the tumor. I tend to be pretty aggressive at giving radiosurgery, if I see any evidence of growth or change in the size of it. I'm not sure I would call that upfront radiosurgery. It's kind of like, do you do radiosurgery sooner rather than later type of strategy there. Okay, I think I've gotten through all the questions. I wanted to thank everybody for your attendance tonight. Hopefully this was an informative discussion on kind of how we as neurosurgeons think about meningiomas in behind the scenes in terms of trying to get the patient to an operation safely. The next webinar would be in March of 2024, and the topic will be posted as we get closer to that time. Thank you, everybody. Thank you for attending tonight, everybody. Enjoy the rest of your evening. Take care. Bye-bye.
Thank you, Dr. Chang.